my emergency medicine colleague. This is Dr. Josh Lynch, who I just recently met a few weeks ago and learned a piece of some of the amazing work he's been doing up in Buffalo and in the whole northern half of New York State, and extending that care into New York City. So without a lot of fancy introductions, I so appreciate that you're here. I want to welcome you to our group that is really interested in hearing about your work and how we can replicate some of this integrated model here. So thank you.
Great, thank you. Thank you very much. Excellent. So thanks for the introduction. I'm Josh Lynch. I'm an emergency physician from Buffalo, and a few years ago tried to think about a way to better refer patients to opiate use disorder care out of the emergency department. And fast forward to today, now I'm the medical director of the New York Matters program, or Matters for short. And this is really kind of a collaboration between a whole bunch of different agencies, but primarily the University at Buffalo and UBMD Emergency Medicine, with some platform support from the New York State Department of Health. So before we really get into the program itself, I'd like to level set everyone and just take a step back for a minute and think about a patient in withdrawal, and probably doesn't take long to think about a specific patient, and maybe that's a family member of yours or a patient you've cared for recently. And I just want to remember how difficult for a patient to kind of come up and go seek care. And sometimes it takes a long time to convince somebody to go seek care. And I really don't blame them for not wanting to, because as a health system, we haven't done the best job at getting patients hooked up to the appropriate care. And I think that, an example in the emergency departments is that for a long time, we've given patients a list of phone numbers of clinics that we know that exist in the community. But we, being honest with ourselves, that we don't vet the list. We never really updated it very often. It wasn't a priority. And that list often had phone numbers that didn't work, or clinics that didn't take the patient's insurance. And oftentimes that list ended up right in the garbage or on the emergency department stretcher in the same pile that we gave it to the patient. So, I think that pacified us to a certain extent to say, well, we gave the patient a list. They'll call and they'll get followed up, no problem. And oftentimes the patient really kind of ended up right back where they started. And it's I think that opiate use disorder and even substance use disorder care in general is a disease process that's easy to put on the back burner. We'd never get away with treating a patient with chest pain like that, and it's just something that almost is perceived as an unsolvable problem. And again, can't really blame the doctors for not having a better system. It's really a problem that how do you know where to start? And we knew that we could do better. And again, it's just where do you start? Like, you have a bunch of clinics that are full, and a bunch of patients that are perceived to not have insurance or to be difficult. And it's really tough to say, all right, let's start here and try to get our hands around this. And that's really kind of where the Matters concept began. And we started to look at obstacles that opiate use disorder patients face. And we all know there's a lot. And any one of those obstacles that are kind of thrown in the patient's way is enough to derail the referral process and derail them from even going to care again. And certainly not following up, and probably not coming back to our emergency department because the experience really wasn't there, and the quality wasn't there either. So it's easier to think of New York Matters really as a collection of resources, really all aimed at trying to help the patient overcome these obstacles that we're all very familiar with. We'll walk through some of these specific circles on the infographic here as we go forward. This program is not just me. There's a bunch of great physicians in Buffalo that have worked really hard with me to set this up, and our program coordinator, our program manager, and our community engagement specialist, Kaylee Logren and Lucy Connery, have been really instrumental in making sure that this program runs on a day-to-day basis. can't give a lecture about this program without thanking the folks that have made it possible. And here you have represented local, state, and federal agencies that have really supported us, and a special shout out to the John R. O'Shea Foundation, who gave us money when we didn't really know what we were doing, and really believed in our proposal and believed in us, and we're thankful they did, because here we are today. So if you think of the Matters concept as kind of living in the third space here between a whole bunch of referral environments and a network of outpatient, high quality, medication-focused treatment organizations, that's probably the easiest way to think of what the Matters resource collection provides. And as I mentioned before, this started in the emergency department, trying to link patients to care and provide them some wraparound services in the process. But we realized really quickly that our inpatient colleagues, our hospitalist colleagues, needed the same type of support, and actually our law enforcement and EMS partners needed the same type of support, and we're having the same type of problems dealing with patients with substance use disorder and getting them hooked up too. I think we all get frustrated and a bit discouraged when we see the same patient come back with the same problem, regardless of what it is, knowing that we didn't do a great job the last time and we didn't fix the problem. Or get them to a place that could help keep them retained. And then obviously telemedicine has played a huge role in this, and we'll walk through kind of what that means a little bit later. So let's take it even look at it in a more simple way. The goals of the patient encounter and the core goals of the Matters program is to provide an effective evaluation of the patient, whether that's in the inpatient side, in the ED, on the side of the road with the police department. We know now that medication does the heavy lifting, and providing medication to patients and prioritizing that, not holding the medication hostage to a certain number of other boxes that need to be checked, such as a certain amount of counseling visits or group visits or other things. Not to say that those aren't helpful, but we believe strongly that medication is really the key, and that is what gets people to care and keeps them in treatment. And then a quick and effective referral to a high quality, primarily outpatient treatment organization is really the last goal. So this program was kind of born and developed in Buffalo, and we really kind of started to branch out across Western New York into just south of Rochester, and then kind of traveled our way along the thruway, literally and figuratively, working on building relationships as we traveled east. We spent a lot of time in the capital region working with the Department of Health to build the electronic patient data exchange platform, and then have really kind of worked our way up from New York City, up through the Hudson Valley, and recently brought on a bunch of partners in Suffolk County and Nassau County out in Long Island. So just for reference, the yellow markers here are organizations that we've met with. We are working through the onboarding process, which is not tricky and not lengthy, but certain hospitals need to have certain steps before they can be really brought on board. So the mission, vision, values document here really has one take-home point. Are some responsibilities that we ask of the community-based treatment organizations, and it's really just one ask. Take patients how they come. At 2 o'clock or 3 o'clock in the morning on a Sunday, we want the program to be as effective as it is as business hours during the week. So partners that we've brought on board have agreed to take patients with whatever baggage they come with. And we offer the same opportunities and same resources to referral for a patient that has been using opioids for a few months, that has a job in a car, and maybe looks like this person, as we do the polysubstance user who's uninsured, who doesn't have a ride, and is really kind of a very complicated patient. So we also understand that our colleagues may not be as comfortable using buprenorphine as others. And we often see that people will go through the X waiver process. Thankfully, it's a lot shorter now. And get their X waiver and never prescribe buprenorphine. And we kind of asked why, we asked some of those people why that happened. And the answer oftentimes was, I don't know where to start, and I'm not 100% comfortable. So the first step of our referral platform just reminds our provider colleagues with just a simple protocol that's pretty low threshold, and basically indicates if the patient's in withdrawal, they get buprenorphine, and if they're not, then they don't. and just kind of walks through a very simple way to initiate in the emergency department and write a prescription. We'll talk a little bit about the referral process specifically, and then kind of walk through the voucher process and the naloxone components that we have too. So there's a few ways to get to the referral program. We started off by giving iPads out to every hospital location that was referring. Some hospitals got a couple iPads, depending on how big their ED was and if their hospitalists were referring. But really, we realized that sometimes iPads are a hindrance. Where's the iPad? Who has it? Oh, here it is. It's not charged. So we started to try to figure out other ways that could be appealing and easy for physicians and other healthcare professionals to provide referrals. So on the mattersnetwork.org website, there is a professional referral button over on the left. That is one other way to get there. And more recently, we started to develop referral stickers. So we put these stickers, they're about 2 inches by 3 inches. We strategically stick them where healthcare professionals would be either dictating or doing discharge summaries. We also are targeting case managers or discharge planners. And all you have to do is snap the QR code, type a quick authentication phrase or a passphrase in to get onto the referral platform, and it's just one other easy way to get patients linked up. And then lastly, I think the most exciting thing, which is kind of version 3, is we have an app in development for iOS and for Android that should be up and running in the next month or two. This will provide referral platform access to healthcare professionals, EMS providers, and other first responders, such as law enforcement, and also a whole bunch of resources for patients. So opening up the app, you select who you are, and that will take you to the second page of what type of resources are appropriate for you. This was developed with support from the University at Buffalo Clinical and Research Institute on Addictions. So this is the actual first page of the patient data exchange or referral platform itself. And as you'll see here, this is housed on the New York State Department of Health Commerce System. And if you're not familiar with that, that is the state's database for sensitive information. So our prescription drug monitoring program is located on this server. Our death certificates are populated and maintained on here as well. You have to have fairly significant credentials to have access to this. It's one of those types of websites where you have to change your password every few weeks, and it's something that takes a 15-minute process to come up with a unique password for. So it's one of those platforms, and also really one of the only places that sensitive patient data could live from a whole bunch of different unaffiliated hospitals being exchanged to a whole bunch of unaffiliated clinics out in the community. And there's really not many options of where that data can be housed and be shared. So running through the referral process, it's very quick. We just ask for a few pieces of demographic information from the patient. Now, this can look a few different ways. Some with iPads, we usually give them to the patient and let the patient fill it out. Oftentimes, for some patients, this might be the first time that they're actually taking some initiative and doing something to get themselves on the road to recovery. Other times, if the doctor accessed this from their phone, maybe they want to hold on to their phone and fill out the referral sitting next to the patient. So we ask for some demographic information. We ask what kind of health insurance they have, and we ask if they need transportation assistance. So if you think back to the mission, vision, value statement, none of these questions can disqualify the patient from any referral sites or receiving sites that we have in our network. These questions are asked deliberately to provide them with additional resources, which I'll explain in a minute. We do ask for some other information in regards to past medical history and past treatments for opiate use disorder and that the patient has encountered before. Again, this doesn't disqualify them or change any of their opportunities. It simply is helpful to the treatment organizations where the patient's being referred to so that they know kind of who they're getting and what they're working with. Then we ask where the patient's being referred from, and that'll come into play in a minute. You'll see a clause here, and there's a couple other clauses that the patient has to check, that they understand that this data is running through a New York State Department of Health platform and may be used for public health activities in a de-identified way. We have a few data collection questions that are based on what type of referral environment the patient is in. So in the emergency department or in the inpatient setting, we might ask questions about, did the patient get a buprenorphine prescription? If they did, how much did they get? Did they get Narcan given to them before they left? Obviously, a police or fire scene might look a little bit different. We have different questions that are appropriate for them. In addition, correctional facilities or law enforcement type environments would be different as well. So think back to the piece of paper that we gave the patient with a list of phone numbers. Probably didn't work. Typically, remember these papers or these referral lists were just really kind of left in the garbage. So this is the game changer. The next thing the patient sees, based on their zip code that was entered a few steps before, is a list or a map of clinics that could be close to their house. This is totally agnostic. So if you're being seen at hospital system A, the clinic choices that you have don't change based on where you're sitting today. So you could pick hospital system B's outpatient clinic while you're sitting in hospital system A's emergency department. And as you can imagine, that sometimes gets a little sticky when we're setting this stuff up, right? Luckily, we've worked through those issues with our hospital partners, and they understand that it's really important for the patient to pick where they want to go, and the patient likely cares a bit less about who's affiliated with who and who is owned by who. So when the patient clicks on any of these markers, what they'll see is an expanded view of what type of medications are offered at that location, and also what it is, what's the name of the place and where it is. This is important because patients may have preconceived notions or may know somebody that went to this clinic and said that, hey, the staff there's really nice, I want to go to that place. Or they may find their house on the map or apartment on the map and pick a place that's on a bus route or they can walk to. So it's really important to display this geographically. I'm excited to mention that in the next few weeks, within that box will also be displayed if that location offers mental health treatment, hepatitis and HIV screening and treatment, other substance use disorders besides opioids, and COVID testing and vaccination services. We understand that this is a very fragile population. They may never go to their appointment, but if they do, we want them to have the best chance of success in being at the place that can address all of their needs. Now, you might look at this list and say, wow, these are all tricky things to treat. Substance use disorder, mental health, hepatitis, HIV, like these are all the tough ones. Yeah, we know they're all the tough ones. And that's why I want to make sure that the patient can get under one roof that offers the things that they need. So that stuff's coming soon. The next is they'll pick a date. So if they click on the clinic and then hit select date, all of that clinic location's availability will show up here. If they don't, they can just go to a list view and look to see when the next available appointment is anywhere. Across New York State, we have about 300 to 350 weekly appointment slots, so there's plenty. And typically the appointment would be listed for the next day. This list will look a little different too when we have the mental health and hepatitis and HIV treatment displayed, but we want to make sure the patient knows what's offered at each place. Once they hit select, a whole bunch of things happen behind the scenes. This is really kind of, I think, one of the best parts of our program, is that all of this happens electronically and automatically behind the scenes. No phone calls are made at all by the healthcare professional or whoever's making the referral. So information comes back to where the patient's being referred from. In most emergency departments, that's to a fax machine. If you haven't been to an emergency department in a while, I've been to a lot. I'll tell you, there's still fax machines in emergency departments. They're normally next to the secretary. We want to give the patient something physical in their hand to walk out with. That's important. We also send the patient's information to the clinic that they've picked to go follow up at. If they don't have insurance, we issue them a medication voucher up to 2 weeks of buprenorphine coverage automatically, no questions asked, no waiting period. I'll show you what that looks like in a minute. If they indicated that they need transportation assistance, we issue them instructions on how to get an Uber voucher that we cover the cost for their first round trip to their appointment. Again, no questions asked, no waiting period. Limited information would go to a peer network associated with that referral site. So if the patient, one other question that you might not have seen in the slides earlier was, if the patient has the choice to say, I would like to be contacted by a peer in recovery for support. So if they do, limited information, not all their medical history goes to the peer organization, really just their name and phone number and email. The peer organization can reach out to that patient and kind of virtually hold their hand until they get to their first appointment. An email goes to the patient as well, and a text message goes to the patient. You might be thinking, wow, that's a lot of redundancy. Well, I'll tell you, this patient population needs it. So we want to make sure that they have a ton of different modalities so they have the greatest chance of getting to their appointment. This is one example of what the referral paperwork looks like. So this is what gets emailed to you when you select an appointment, and also gets printed out back at the emergency department or wherever they're being referred from. You'll notice in the middle, the first dose at home. We don't call it home induction. Home induction sounds intimidating to a patient and is frankly intimidating to some of my colleagues. We call it first dose in the hospital or first dose at home. And the first dose at home is basically just home induction instructions. Buried in there, you'll see COWS criteria. We tell the patient that you should have at least 3 of the following symptoms before taking your first dose. And if you take your first dose too early, the medication can cause withdrawal symptoms and make you feel, quote, really bad. So we want to make sure patients understand when to take the first dose if they're not getting it in front of it while we're caring for them directly. This is what part of the voucher looks like. There's a randomly generated voucher number that gets assigned to the patient that can be verified by the pharmacy later. But we've partnered with Walgreens, Wegmans, and CVS. We're working on partnering with Rite Aid and another couple pharmacy chains across New York State. But the prescription can be sent to any one of these pharmacy organizations. And then, like I said, we cover the cost of up to 2 weeks of any buprenorphine formulation. And you'll see up above there, it's not just in New York. We've partnered with Walgreens and CVS to accept our vouchers in the neighboring states as well. We have a big telemedicine component, and I'll get into this in just a minute. But we wanted to make sure that patients were totally comfortable if they had to start buprenorphine at home, how they would do it. This is just an instruction sheet that we can give to the patients as well. It's also on the website under the patient resources area. And it just explains kind of in more detail what the patient should expect if they have to take their buprenorphine at home. I had mentioned the fact that patients are given instructions for an Uber Health voucher to be issued to cover their first round trip ride to their first appointment. We're also working with another transportation organization that is actually nationwide that can help offer additional transportation assistance for patients as well. Again, the whole point of this is to take out the huge barriers that patients have commonly faced, such as access to medication and transportation. So for patients that none of that's going to work for, we've really stood up and expanded our telemedicine initiatives, starting from the very beginning with virtual emergency departments. For full disclosure, this wasn't started as an addiction initiative initially. Just after St. Patrick's Day of last year, we knew we had to figure out a way for patients to access emergency care that didn't involve coming to the hospital. So we stood up 2 virtual emergency departments in March of 2020, and that allows patients to schedule a virtual emergency department with an emergency provider, and they can be assessed over a telemedicine platform and also have e-prescribing capabilities, including controlled substances, for patients that were at that time afraid to come to the hospital. And we realized very early on that, wow, patients suffering with addiction are accessing this system like disproportionately. And it didn't take long for us to think, wow, these are people that probably should have been seeking care the whole time that just didn't, and they didn't for a variety of reasons. But this was a quick access for them, and we really kind of modified our platform and our system to be able to accommodate and treat them. We've also established relationships for ongoing virtual treatment, and I'll explain what that means in just another slide or two. And then there are also patients that interact with police in indirect ways. So police may go to a domestic violence situation or a shoplifting situation and realize at the scene that, wow, this behavior is related to substance use disorder. And typically they don't have many options for what to do in those cases. We've partnered with a few police departments as a pilot project to have officers identify patients who might benefit from an assessment. It looks a little bit different based on which police department you're working with, but some have either via their phones or their computers in their cars or cellular-based iPads that we gave them. They can set up an on-the-fly emergency evaluation with our emergency telemedicine providers we can assess the patient on the side of the road in the back of the police car at their kitchen table, fill out a record on our cloud-based electronic medical record, and then even prescribe buprenorphine without the patient ever leaving their house. One other kind of way that we approach that is if the patient comes to the police department, we can provide that service via kind of a kiosk at those police departments. So if you think about it, these patients have had a history of going to the police department, getting arrested, spending the night in jail, having a horrible experience, leaving probably worse than they were when they came. And in this kind of reimagined experience, the patient goes to the police station, they get in front of an ER doctor or PA or a nurse practitioner, they get assessed for their real problem, which is causing the legal issues. They get linked to an appointment the next day, might get hooked up with Narcan, and probably leave a bit better than when they came. This is a really exciting partnership that is in the works right now. So Matters is partnering with Reach Medical, which is a statewide tele-addiction treatment program. So we knew we needed a way, especially in kind of the far corners of New York State, the Adirondacks, central New York, where there's not a ton of resources and no Uber and probably no ride-sharing programs at all, to access patients that needed help or reach them. So we're partnering with Reach Medical to be a virtual receiving site. So when the patient's looking through the referral platform, in addition to physical brick and mortar places, they'll be able to have themselves be referred to Reach Medical, which will continue their care totally virtually. So this is a real exciting partnership. Kind of more to come on that as we build this out and really operationalize it. But we're really excited to do it. It's not totally up and running yet, but I wanted to include that today because I think it's a big part of accessing care for patients that are really way outside of any major town or cities. What you might not know about the University at Buffalo Emergency Telemedicine Program is actually it's been around for over 20 years. We've been providing emergency telemedicine service to the New York State Department of Corrections for greater than 20 years and have provided greater than 30,000 consults. This is really exciting because we have kind of ingrained in both our residency program and across our faculty what emergency telemedicine really is. Some people that doesn't really sound intuitive, emergency telemedicine. But we've been running cardiac arrest over telemedicine in correctional facilities while we're waiting for the ambulance to clear security. And we've expanded to a whole bunch of different applications such as the virtual emergency departments, helping to get approval and authorization for monoclonal antibody infusions for COVID, and in addition to a few other different initiatives as well. So couple notes on naloxone, right? That's a key part of any opiate use disorder program. In addition to offering naloxone kits to anybody that's in the emergency department or anybody that's going through the referral process, we also have been building and expanding a leave behind naloxone program. So we equip EMS providers with naloxone that's covered by the Department of Health, and they have at their discretion the ability to leave naloxone at the scene of any call that they think is opiate related. So if there's an overdose at someone's house, they can leave naloxone at the house, no questions asked. At a gas station, at a grocery store, at a restaurant. That's been really important in getting naloxone out into our community. We also have naloxone wall-mounted boxes that we have put through public transit, typically next to AEDs. And then we also have a text for Narcan program in New York State that you can simply text a number and we'll mail you a box of Narcan. We don't care why or where or what's going on, we'll just mail it to you. One other enhancement to the take-home naloxone program is the addition of fentanyl test strips. We now include fentanyl test strips in every box of naloxone that we are giving out. We also have a sticker that you'll see there with a little QR code on it that gives some instructions on the fentanyl test strips. The test strips really don't come with any instructions, so we have linked to a pretty slick video that we did not make that is out there that just shows someone how to use that. This is totally harm reduction here, right? And maybe controversial in some circles, but we felt that it's really important, especially with the prevalence of fentanyl, not only in opioids but also in other drugs that folks are using and inadvertently are exposed to high potency opioids. We're working with the Department of Health to extract some data from the patient data exchange platform. It's still in its infancy. We're also working with closing the loop on retention in treatment, which when you work with the Department of Health on things like that, it takes a while, especially when you're talking about 50 or 60 different hospitals and 200 or 300 different clinics that are out across the state. This is some of the data that we're looking at now about where patients are being referred from and what frequency. We're hoping to see this county map become much more dense as we move forward. Just some information about peer referrals. So the top bars are no. There's not a legend on here. The top portion of the bars are no, and the bottom portions are yes. So for peer support requested in the third quarter of this year, you'll see 92 patients asked for it. 92 patients did not. Interestingly enough, half and half. We also have some data on naloxone kits distributed, patients receiving buprenorphine prescriptions, and patients who are in withdrawal and getting buprenorphine before discharge. So those numbers are about two-thirds in the third quarter of this year for patients that received a buprenorphine prescription and received buprenorphine prior to discharge that were in withdrawal. This is really important, and it's also, I think, it's worth thinking about what the baseline here looked like, right? I think we were all pretty familiar with the data point that said only 10% of patients with opiate use disorder actually get care. Thinking about now having two-thirds of patients that show up in withdrawal get buprenorphine before they leave, that's a huge step. Not all the way there yet, but certainly heading in the right direction. So just kind of to summarize, we think we've built a pretty robust network across New York State. We're really excited to look to the neighboring states to help partner for circumstances like, I'm a patient who overdosed in New York City, but I live in New Jersey. How does that type of referral step look like? It really doesn't look like anything right now, but we are working with stakeholders in Pennsylvania and New Jersey to help kind of replicate this system and expand pieces of it across the state lines to help patients in a more comprehensive manner. We talked a little bit about the transportation and medication voucher program, the peer referrals, diversifying referral sources in addition to the environments that we talked about. And then again, looking at other states, even out west, that are interested in kind of how this system has worked. I will mention one thing, and you might have figured it out already. The whole Matters concept really is built on linking existing resources. So this is not a $20 or $30 million statewide program. This is adding a few FTEs to the mix, building an electronic platform, having some infrastructure, and linking existing community resources that are already there. We're not building anything, and again, we're not hiring a ton of people. So this really is only a couple $1 million program to function across the entire New York State, which is really, I think, reproducible in other areas too, especially in a cost-effective manner where you're trying not to build a lot more infrastructure. So what's next? Earlier this year, the New York State passed some preliminary legislation about having the New York State Department of Corrections have to provide access to medication for opiate use disorder within the state prison system, which is not the case, which hasn't been the case. This is two parts, right? Trying to figure out how to administer medication safely within the prison system, and then also what to do with individuals when they're about to be released. We're all aware, released from prison or after a period of abstinence is a huge risk in a patient's recovery. So we believe that the Matters platform is probably a pretty good solution for linking patients to care when they're about ready to be released from prison or jail or other periods of abstinence. Thanks to our colleagues in Camden, New Jersey at Cooper Health, they have really pioneered the concept of EMS buprenorphine. We are working with New York State to pilot some projects around New York State to give buprenorphine for naloxone precipitated withdrawal or naloxone induced withdrawal, and then be able to link those patients right to care from their home or wherever the site of the overdose was. And then I had mentioned inclusion of mental health, super important, especially now that we also link patients to high quality mental health care in a timely manner. So this was really the presentation. I just want you to think back to how we used to do things and how things really look different. And all this program and most of the information that we talked about today is available at mattersnetwork.org, or you can snap the QR here and that'll take you right there as well. If you have any questions, we're happy to talk now. If you think of something later, you can go back to the website, fill out the contact form. It's really just a team of a couple of us, so it won't get lost anywhere. And we'll get back to you and certainly address your question. If you have desires to try to replicate this type of process in your area, also please reach out, and we'll open it up for questions, or I'll turn it back over. Thank you.
Thanks so much, Josh. I know we're going to have a lot of questions. Maybe we can get started with whoever wants to start. I see Kit's camera on.
Yeah, I'm just blown away, Josh. I sort of followed you loosely in your matters on Twitter, and just really impressed with all the work that you guys have done and success. I think we're very envious, because I think we aspire to that kind of sort of infrastructure, but we're nowhere close in terms of connecting all the pieces. So just kudos. I'm curious in terms of your have you looked at how often you're able to get people from the ED into treatment? I mean, I think that's the hard outcome to measure, and you might actually be able to measure that with your infrastructure. For us, that's a hard outcome to measure, because we don't have a data infrastructure for people outside of our system.
Yeah, great. That's the $1 million question. Thanks for the kind words and for an impossible question to answer at the end. Just kidding. So yeah, so we actually have a process that's being built now inside of the electronic referral platform, actually on the Department of Health Commerce system, which will automatically ping a clinic a couple days after the appointment was scheduled for, and then they'll be able to answer 3 or 4 questions. Yes, the patient came to the appointment. Yes, they're on buprenorphine, or no, they're not, and here's why. And our research friends within our department really wanted to know how much bupe they were still on, so we can help kind of look back to say what's a good number for most people. I think there have been other studies that have looked at that from different angles, but we want to know specifically retention into treatment, and if retention in treatment really is dependent on dose. Is it dose dependent for bupe or not? So I'll just tell you, this has no p-value assigned to it, but we looked at a sample of about 150 to 200 patients, and it looks like their first appointment show rate was about 60%. So compared to the 10%, if this was a non-addiction savvy audience, 60% would not be a success. I think in the addiction world, 60% for first appointment show rate, is pretty decent. We're obviously working to try to increase that number, but we're very happy with where we're at so far. Thanks for the question.
That's fantastic. I have to ask. Sorry, just the question about phones. I know this came up last time. We're so reliant on phones for this network, for Ubers, for telehealth. Do you dispense phones, and how do you help with phone retention?
Yeah, we don't dispense phones. We've worked with some homeless outreach partners in New York City, and also in the Western New York area. And one of those programs involved handing out a prepaid phone to individuals that were experiencing homelessness and trying to retain them that way. And to be honest, counterintuitively, it really didn't work. What worked better was, we're going to meet you here tomorrow at this park, or at this corner, or at this whatever. And that seemed to work better. So that was kind of the model that has now continued in New York City with a couple different organizations. Additionally, what tends to happen, and this shouldn't be a surprise, is that if we give a patient a referral, we send them home with the paperwork, they don't have a phone, they don't have email, they don't have anything. The patients usually will kind of wander in or around that treatment clinic on the day that they were referred. And that's part of kind of the onboarding process too, right? Is that we walk through the mission, vision, value statement. We explain that we really need that organization to take patients regardless of their complications. And we also let them know that at times patients may just kind of wander in with our referral packet in hand. And if you could see them when they wander in, that would be greatly appreciated. We also follow up with every single patient that gets referred, and that's kind of on a regional, that will be on a regional basis. We have the ability to re-refer them on the phone or on the fly. If we call them and they say they couldn't get to their appointment, we'll give them a new referral right away. So that's kind of a quality check. Also, early on we started following up with patients, and they said, hey, you know what? They wouldn't give me another prescription until I went to 2 group sessions and 3 counseling appointments. That's not really what we all agreed to in the beginning. So we circle back with clinics, close the loop, make sure that they understand. Sometimes an organization might lose their grant-funded nurse practitioner overnight. And in those cases, the referral platform and appointment availability is very flexible. So they have the ability to pull that back. We have the ability to pull that back right away. Hey, someone just quit, or hey, we lost our grant funding. We need to pull back our availability from 2 appointments every day to 1 appointment on Mondays and Fridays. We can change that on the fly. One other thing I didn't include here is that we just received funding to hire 9 regional care coordinators across the state. So we broke the state out into regions. We're going to have a full-time regional care coordinator in each one of the regions, and they will work with us to kind of really hammer that region. And that may look different. If you think back to the map, Western New York is pretty well populated with partners. So that regional care coordinator's job will be really to focus on referrals and also enhancing the network in that area. The regional care coordinator up in the North Country, up by Lake Placid, their job will be much different. Their job will be going out, forming new relationships, enhancing telemedicine services, finding gaps in coverage, and working through that. So we're excited to bring those 9 additional members under the Matters umbrella over the next 2 to 6 weeks, and really try to enhance the network kind of region by region.
Great. Some questions in the chat too. I know Krishna, looks like you maybe have some experience in Delaware. I know that's where you came from. So I know some other people who have been trying to work on care in Delaware. I don't know if you want to ask your question. You wrote that there's a similar network in Delaware, maybe a similar bed finding program.
Yeah, I had met with some Department of Health folks from Delaware over the last few months and learned a little bit about their system, which is really great. But we'd love to connect offline. I think so. Lucy Connery is our community engagement specialist who was handling our chat questions while we were talking about other things. But yes, Krishna, that would be great. I mean, we'd love to talk in more detail, and if there's a way that we can refer people back and forth and across the system, that would be awesome. Feedback about the fentanyl test strips. I have to admit, we were a little nervous about the response of really putting fentanyl test strips out into the public, really. Thankfully in New York, we are allowed to. And I know in other states they're not, and in other parts of other states they're not legal. But we thought it was really important. And I see patients personally in the emergency department that have been using cocaine and come in an opiate withdrawal and are shocked as to how that possibly could have happened. And I think that fentanyl test strips are a key part of harm reduction and are really needed for certain patients.
So were you worried about, because I'm concerned about sort of more hospital administration. They've been decriminalized here, but they're not legal. We sort of try to fly under the radar with some things, and I wouldn't be as worried about the community as, within the programs, in the health system.
Full disclosure, we try to run under the radar too. We'll leave it there.
It's not something I would go right to the administration and ask about.
Right, but so our naloxone kits are received by the Department of Pharmacy, and our Pyxis or Omnicell are also restocked by the pharmacy staff. So we thought it would be right to include the pharmacy leadership in on what we were going to be sticking in the Narcan boxes that were sitting on their shelves. Well, we thought it wouldn't be right if we didn't. And actually, there were some questions, and we explained the importance of it and literally how it could be life-saving, and there was no issue. But we also had similar encounters when we were trying to put Narcan in the Pyxis in the very beginning, or when we had Narcan trainings for the nursing staff to take Narcan home with them themselves, or train the security guards at the hospitals to carry Narcan. So I think this was just one other thing that we needed to have a really frank and honest discussion about everyone's concerns, and we got to a point very quickly that everyone was comfortable.
Great. Thanks for that. Catherine, you want to unmute and ask your question? Or you could say no. But I'd like to hear more about how you developed so many outpatient sites. If that was covered at the beginning, I'll rewatch the video. Did sites elect to join? Are there treatment agreements, et cetera?
Well, so it was kind of interesting. This was really pleading with the first few sites to come on board and offer some enhanced availability, and being willing to take patients regardless of the screening process or onboarding. And some sites initially had kind of strict criteria about who they would take and who they wouldn't, who was eligible for BUP and who wasn't. And we really kind of came into those groups and said, we want to do something that includes none of that. And that was a hard sell at first. The first dozen clinics, that was kind of a rough discussion to have. I think everybody knew that was what we needed to get to, but it really wasn't easy to get there. So the first few clinics we had a lot of dialogue with, a lot of discussions with. And really, we came to those meetings with the clinic organization leadership with just the one-page mission, vision, values. Admittedly, we didn't have anything else to bring with us, so we brought that. But we wanted to explain to them what it was like from the ER's perspective. Like, I want to refer them to you, but I can't figure out if they have this insurance, then what does that mean? If they're also using benzos, what does that mean for follow-up and eligibility for medication? So that was really the pitch. Once we got critical mass in Western New York, there were some holdout organizations that weren't sure that they could deliver that type of care. Once we got critical mass, it was fairly easy then, easy for the rest of them to pick up. So we would work with them. Some folks came on for a little while. We found in patient follow-up calls that the experience was not what we promised. So we pulled, they came off the network for a few months while they regrouped internally, readjusted their approach to things, set up some appointments that were kind of fast-track appointments rather than the traditional, process that the patients normally would have to go through, the onboarding process and assessments, and they changed. So now we tried to carbon copy what we were doing in Buffalo in Albany. There was some funding available to pick up half of an FTE in Albany, who kind of acted as our regional coordinator out there. And she started working with hospitals and clinic partners out there and had similar discussions with them. I made a lot of trips down the 90 from Buffalo to Albany and met with hospitals and clinics myself to explain the concept and the process. And then it just kind of started to ramp up. Then we started to meet with clinics as big groups and pitch the concept. We would give out enrollment forms to give some availability to start. I think the other thing that made it fairly attractive was that if you weren't sure about how this was going to work, just give us one appointment a week, and then we'd go to the next clinic and give us one appointment a week. So the more places that participate in any one region, the better the network is in that region, and everybody contributes a little bit. And now we have a very robust referral system in that area, and no one organization is overwhelmed. Then the ability for us to turn on and off the spigot. So if you're overwhelmed or you're having a bad month, just shut the appointment availability off, and then we'll turn it back on when you're ready. So that not having to have an organization commit to 6 months of 2 appointments Monday, Wednesday, Friday, and have the ability to flex on the fly, I think also kind of lowers the barrier of jumping on and just dipping your toes in the water and giving a little bit of availability first to see how it goes. So hope that answered the question.
Yeah, that's great. Yeah, she said thank you. I'm thinking but so then what do you do about the emergency departments in Albany? Like the emergency departments were already doing this work and needed referral sites, or?
So on the emergency department, department side. Some places had a couple champions and were getting the docs to have X waivers and were comfortable using BUP. Others wanted nothing to do with it. So those approaches were a little bit different also. The places that were okay with BUP and had X-Wave providers, those were easy. Those places really just needed to be told how to refer patients, and they were thrilled. Others took a bit more work. So the departments with medical directors that wanted nothing to do with buprenorphine in their emergency department because they thought it would cause drug users to kick down the door and come in by the thousands. I'll tell you, in onboarding 40 or 50 hospitals, we've never had that happen. We've had upticks, but it's never been overwhelming. It's never been crazy or unexpected. But also realizing that this makes life easier for the ER doctor. There's no phone calls. At the end of the day, you can sleep better at night knowing that you're referring patients to good care, just like we would do with a chest pain patient or a patient that needed obstetrical follow-up. And it's quick. None of us like making phone calls and sitting on hold. This eliminates all of that. This can be done. The referral process doesn't have to be done by the doctor either. It can be done by a nurse. At some hospitals, it's done by the drug and alcohol counselors or peers that may staff the ED anyway. So the referral process is really designed to be equally as effective in the smallest critical access hospital or the largest tertiary academic center. So if there's addiction medicine fellows, sometimes they come down and do the referral during the day when they're there, and then at night it's the ED staff. Other times, if it's a critical access hospital, it just might be the attending because that's all there is. Or the secretary could do it. So it's really easy to do and deliberately applicable to any kind of healthcare professional to provide the referral process, which really only takes about 2 minutes.
Yeah, that's great. We're so amazed because we have patients that come in really even during the daytime and we can't get them an appointment, but forget about it for evenings and overnights and weekends, and then they don't have a phone, so meeting them on a corner doesn't work because we don't know what corner to schedule them for the following week. So we're just losing a lot of people who are good BUP eligible, but the follow-up gap is creating a problem.
Yeah, incorporating the map has really helped, especially for people who don't necessarily have a home, that say, you know what, I know somebody that lives over there. I'm going to go to that clinic because I can go to their apartment or I can go to their convenience store before or after. And a lot of that is how some of this really goes down, right? I mean, or the bus, that I can take the bus to that corner and that clinic's right there. So seeing the map and be able to zoom in and zoom out and click the addresses and places, the clinic names has really been a big help. It used to just all be on paper initially, and that was like the first, I guess the second iteration. We knew we needed to get to electronic. It was just, it took a few steps to get there.
Yeah,
But again, there's a ton of resources on the website. There's some explainer videos about how the process works. We also have some videos that we direct patients to. Part of their discharge papers includes a QR code to watch a 3-minute video to say, I just left the emergency department, now what? And it explains to them what to do as far as BUP initiation or induction at home. It explains the referral process and then what to do if they need a little bit more help.
Oh, that's amazing. I like the post videos too. Well, we're getting close to the hour, and I know I've asked a lot of my questions. I know I'm going to have more, and I'm going to take you up on the email follow-up. Josh is also coming to New Jersey to talk to the state of New Jersey on November 29th, and if anyone wants to come, there's also going to be discussions about how to have Philadelphia participating in some aspects of this kind of cross-state talk in the preliminary stages. So it's really exciting to me to have you closer to us to use your resources and your skills and what you've already built. So kudos, thank you, and really appreciate it. So this will be recorded. It was recorded. It'll be posted on our website, hopefully for you and for other people to watch if they missed it. So thank you so much for coming, and look forward to seeing you in a few weeks.
Thanks, everyone. Have a great rest of the day.
Thanks a lot.
Thanks. And is it